Welcome everyone on the internet. It's a little unusual. Normally when I'm doing this type of a talk, it's with a larger audience. It's nice to not have to worry about hecklers or people throwing things at me. So if you have your popcorn ready, I guess you can throw it at the TV. That's pronounced electrophoretic, Wendy. So I'd like to also thank Arlene and Amy and Boulder Community Health for allowing me to give you this talk on this exciting topic. Again, my name is Brian Nichols. I've been a practicing ophthalmologist in Boulder for more than 20 years. And tonight, I'd like to, I have two goals. One is to cover the basics of cataract surgery, just to bring everybody up to speed. So I'll apologize ahead of time if it's a little basic for a lot of people. And then talk about the latest and greatest technologies, specifically new technology that we're bringing to the state, the light adjustable lens. So to get started, the eye is a little bit like a digital camera. There's a lens in front and film in the back, and the eye actually has two lenses. There's the natural lens that sits inside of the eye. There's also a cornea, which is a clear dome on the surface of the eye. Both of these structures focus the light to a single point in the back of the eye on the retina, where the light is perceived and sent to the brain, and that's what we call human vision. A few other topics I'd just like to define so that we can talk about these later on and how they apply to cataract surgery, nearsightedness, and farsightedness. As many know, when you are nearsighted, it is easy to see things up close and harder to see things in the distance. And that occurs because the light is focused too soon in front of the eye, as the picture there shows. Farsightedness is the opposite of nearsightedness, where the light is actually, from a physics perspective, focused behind the eye, so that most people who are farsighted typically first notice they're having difficulty reading, but in fact, their vision is not perfect anywhere, and they have to focus through that to properly put the light rays on the correct position in the retina. Let's move on to astigmatism, which is, I find, the most confusing topic to explain to patients and to understand. In its simplest form, astigmatism is out of roundness of the eye, and for most people that occurs on the cornea, on the surface of the eye. And if you think of a basketball as being a spherical surface, a basketball has no astigmatism, whereas a football on its side, where it's steeper across the laces than with the laces, that is the equivalent of astigmatism in a lens. And the result of that is that it blurs the vision because not all the light is focused at the same point. And that has an effect on both distance as well as near vision. And astigmatism is a very common reason why some people who have cataract surgery don't need glasses and others need glasses. So that's often the difference between needing glasses and not needing glasses. The next term I'd like to define is accommodation. So as we all get, as I like to say, less young, we develop the inability to focus our eyes adequately to read. And this is where you need the over-the-counter cheaters to help with reading things up close. Accommodation, which is the focusing of the natural lens to allow you to be able to see things up close, is not completely understood, but we know that it's effectuated by changes in the position and convexity of the natural lens inside of the eye. So as you are looking at something up close with normal accommodation, the lens changes its shape and position to allow the light to be focused, and your focal point is closer to you, allowing you to see things up close. As I alluded to, as the eye ages, it loses that ability. And the range at which, what age you lose that ability varies widely. Some people need reading glasses in their late 30s. Some people don't need them until they're in their late 50s. But it is somewhat inevitable that we all will lose the ability to change the shape and convexity of that natural lens. And that is caused by denaturation of proteins, specifically collagen, so that the lens becomes less flexible. Cataracts are where the natural lens that sits inside of the eye becomes cloudy. And the way to think about this is a piece of plastic sitting on a windowsill for 50 or 60 or 70 years. It becomes yellowed, it can become cloudy, and that is in essence what a cataract is. When the lens is cloudy, just like a cloudy lens in a camera, The eye cannot take a clear picture, and that progressively gets worse with age. It's inevitable. We talk about light exposure being a factor in the development of cataracts, and the data strongly suggests that. However, age and genetics are really the most powerful factors in this. There's no such thing as a 100-year-old that doesn't either have a cataract or hasn't had cataract surgery or doesn't need it. And you can see from this slide, if you look at different ages of lenses, the lens is going to become progressively more cloudy, and that affects the quality of the vision as you're trying to see both distance, intermediate, as well as near. Let's talk a little bit about cataract surgery, since that's the topic for today. Cataract surgery is the most common surgery done in the United States. It's one of the most successful. There are 20,000 to 30,000 cataract surgeries done per day. Greater than 95% of patients who have cataract surgery in the United States enjoy an improvement in vision. In its simplest form, it involves removing the cloudy lens from inside of the eye. Not the whole lens is removed, though. There is a clear capsule that contains the natural lens. We leave that behind because that allows us to have a place or a pocket in which to insert an artificial lens, which is essentially a small piece of plastic. Artificial lenses have been around for a very long time, and they last essentially for the rest of your life. There have been lots of advances since cataract surgery has been invented, including things like smaller incision size, using less irrigation, less swelling, less time. There are lens developments that we'll talk about, safety, using a laser to do cataract surgery. This is just a depiction, a video of how cataract surgery works. You have to make a small incision into the eye. You go into the eye. This is the capsule where we make a tiny little hole on the surface. The lens is then broken up and removed with ultrasound. Then the lens implant is injected. It unfolds similar to a taco, like putting a ship in a bottle into the capsule. And then the wound is self-sealing there, so no sutures these days are typically used. The technique that we use today to remove the lens is called phacoemulsification. It uses sound waves to disintegrate the lens, which is then removed by suction. Originally, the wound size was quite large, 4 or even 5 millimeters. These days, it's 2 to 3 millimeters, and again, that's small enough that we do not really need sutures for that to seal on its own. Other developments include great advancements in the computer that runs this instrument so that much less fluid is used, which causes much less swelling after surgery. Other developments and improvements that have occurred over the decades is the development of the intraocular lens. And the original intraocular lens in the late 40s and 50s was a hard material, polymethyl methacrylate. These days it's a soft, foldable material so that it can be injected in a syringe through the tiny 2 to 3 millimeter incision. It then unfolds inside of that capsule where it sits permanently. So in addition to the things that I've mentioned, there's lots of different front to back processes that are improved, certainly over my career with regards to how we do cataract surgery, much better accuracy of outcomes. Pre-operative measurements are much better, formulas are much better that calculate the lens implant power. Planning software is much better. Surgical techniques, including instrumentation, are much, much better than even 10 years ago. And that leads to better outcomes, and I think that's great news for everyone. How the surgery is performed has changed as well. We have options available. In addition to doing surgery manually, there's techniques that we'll talk about in using a laser, and the laser affords us the opportunity to affect things and treat things that you can't do with the human hand. In addition, something I've started doing recently is a dropless form of cataract surgery, which is of great benefit. No increased cost, no drops, not having to use drops increases healing time, and all my patients have been very happy with that development. As far as lens implant types are concerned, it is a very confusing topic, and they range everywhere from lenses that just correct astigmatism, lenses that are what we call multifocal, lenses that try to focus light both distance and near, accommodating lenses, which are designed to shift in its focus and give better near vision. And the new technology that I'm going to talk at length about tonight is the light adjustable lens. Let's continue to talk about developments and improvements in cataract surgery from front to back. The preoperative measurements, measuring the eye is a process called biometry, and simply that measures the length and the front curvature of the eye. There are additional measurements that are used. Those numbers are punched into multiple different formulas that are used to predict the proper lens implant power that will result in the desired outcome. And I want to expand upon that a little bit. The vast majority of patients would like to have great distance vision without glasses. And these formulas are designed to calculate that for us. However, there is no predictive model that is 100% accurate. And we'll get back to that in a little bit. But the best we can do today in giving someone 20/20 vision without glasses, perfect distance vision without glasses, there is no FDA study of any intraocular lens done that shows a success rate of greater than 80% in achieving that. Most surgeons would say that their results are better than that, and they may be, but it is not 100%. Let's talk about the laser, one of the more recent developments in the last 5 or 6 years. There's a laser called a femtosecond laser. It's used for cataract surgery. And this has really changed and improved the accuracy of the prediction model that I was just talking about. It's developed in 2005, first US case in 2010. And instead of the human hand doing the cutting of the cataract surgery, the laser does that. It's done at the same time of cataract surgery. But the laser, the most important benefit is that the laser can also reshape the surface of the eye to treat any astigmatism that a patient may have in a way that the human hand cannot. The other advantage of the laser is that because the computer is doing the cutting, there is some safety and accuracy benefit over the human hand. This type of a laser is different than the laser used for LASIK or PRK. It's doing some cutting inside of the eye, so it really is an amazingly sophisticated piece of equipment. It uses imaging technology at 50,000 images per second to know exactly in space where it is doing its cutting. So in addition to the surface wounds, so that we can enter the eye to remove the cataract, it's also pre-fragmenting the lens of the eye, and it's also opening that capsule up for us all at the same time. The femtosecond laser is so fast at its beams that it creates what's called a plasma wave, and that's what you see right there in the slide. And it basically makes it a cellular level laser knife. And so the incisions here are incredibly precise. Let's see if we can move forward here. Let's talk a little bit about intraocular lenses. Sir Harold Ridley was the first to develop the intraocular lens in the late 40s. The original material was a hard plastic called polymethyl methacrylate. Intraocular lenses didn't achieve widespread use, though, until the 1970s. Much of the developments since then have been moving towards smaller incisions because of the development of foldable materials. Today, primarily silicone and acrylic, and it's about 50-50 in the United States on the materials that surgeons use in their intraocular lenses. There are a few types of intraocular lenses. The most commonly used is what's called a monofocal lens. A monofocal lens focuses all of the light in one position, meaning it does not give the ability to focus the eye because it has a single focus point. And for most people who have cataract surgery, as I said earlier, the goal is to give good distance vision. Let me define distance vision for you. If you have excellent distance vision after cataract surgery, that means you can see well from about 5 feet away all the way to the mountains. It's a gigantic range, and that's why it is such a popular option. But with a lens like a monofocal lens, it does not allow you to see well in the distance and see up close at the same time. So patients that have cataract surgery with a monofocal lens that have perfect distance vision need reading glasses. They may be over-the-counter cheaters that you buy at Walmart or McGuckins, but those, you need the help to see things up close. Second type of a lens implant I'd like to talk about is a toric lens. This is a lens that's designed for one purpose, to treat astigmatism. So I told you earlier that astigmatism primarily is on the surface of the eye, is on the cornea. A toric lens is oriented in a specific way to negate or neutralize that astigmatism that's on the surface of the eye, and optically that creates much improved vision. But again, this is a form of a monofocal lens, meaning it does not have the ability to focus light. The third class of lens implant types is called a multifocal intraocular lens. And this lens was designed to address the inability of the previously discussed lenses to give both distance and near vision. So it uses alternating rings of light to focus some of the light for distance and some of the light for near. This is different than a progressive bifocal because you're splitting light rays at the same time between distance and near vision. Some are designed for better intermediate as well as distance. Some are designed for better near vision as well as distance vision. There are a few downsides to this type of a lens implant. You cannot defy the laws of physics, so it can result in a decrease in what we call contrast sensitivity, which is the ability to detect different shades of gray in different lighting conditions. It also can give halos around pinpoints of light at night. These kinds of symptoms are called dysphotopsias, and they are a risk whenever you use a multifocal intraocular lens. And the fourth class of lenses that I'd like to talk about is an accommodative intraocular lens. There's only one manufacturer that makes this lens. It's called a crystal lens. The idea here is the lens has flexible hinges, and it's designed to move slightly to give improved near vision. So the idea here is to maintain excellent distance vision because it still is a monofocal lens implant while giving improved intermediate and near vision. The number one complaint of this type of a lens implant is that it gives unpredictable focusing ability between patients. And what I mean by that is it's not unpredictable from a minute-to-minute perspective. Some patients have great success focusing with this lens, and other patients get very little focusing ability with this lens, and it's impossible to predict who's going to get the focusing ability and who is not. So that's a lot of gobbledygook. I mean, there's a ton of information just in the topic of lens implant types. I mean, we've covered single lens power lenses, which is the monofocal lens and the toric lens that corrects really only for distance vision. You can also use that lens to correct only for near, but the point is you don't get both. It gives excellent vision at one distance, but it does not give excellent vision at all distances. Glasses are required again for near work. The multifocal lenses, I think the biggest complaint is that there's an extensive neurological adaptation to it because the brain is trying to use the same lens to do multiple tasks. And some patients do much better with that than others. So there is a little bit of unpredictability with how good the near vision and distance vision is with a multifocal lens. And the same applies to the accommodative lens. Also has a single focal point, but its ability to see distance, intermediate, and near depends upon how successful your brain is at using this lens to focus up close. So modern cataract surgery is very complicated, and discussions with patients can last a very long time, and I often have multiple discussions with patients trying to explain all these things and trying to come up with a plan for what kind of outcome do they want with cataract surgery? What choice do you make? So there's a planning component to that. There's complexity in surgery. So we're using very expensive lasers. We're using lens implants that rely on performing perfect surgery for those lens implants to work properly. And that leads to better post-operative outcomes in general, but because this is all a predictive model, it's really difficult to guarantee or have a high degree in the 90+% success rate in giving a patient what they want, which is, for many patients, I want 20/20 vision. I want 20/20 vision in the distance at least. Some want 20/20 vision, distance, intermediate, and near. And we'll talk about successes and failures in trying to achieve that with these different technologies. So until recently, all cataract surgery is a predictive model. So the measurements are done. This is a little bit like measuring your foot with a ruler and saying, here's your size 9 shoe. You don't get to try it on, it's got glue on it. And if you put this shoe on, it's glued to your foot. Well, you may be an 8.5. You may be a 9.5. There is no way to know for sure that your foot is exactly a size 9 shoe. This extends to any technique. There are techniques for measuring the eye in the operating room after you remove the lens implant. That's a little bit like measuring you for a suit while you're laying down. That's still not going to be 100% predictive of what the outcome will be. So there's no option to try on cataract surgery, really, or to adjust it in a non-invasive manner after cataract surgery. Some patients need to have additional surgery after cataract surgery if they're unhappy with the outcome. They may have LASIK done afterwards, or in some cases, you may have to go back to the operating room and remove that lens and put another one in a process called a lens exchange. But until recently, we have not had a non-invasive way of adjusting the outcome after the surgery has been completed. So let's talk about the light adjustable lens. Pretty simple concept. It sounds science fiction-y. It's a lens implant that you put inside of the eye. After it heals, you use an instrument that emits UV light to incorporate a prescription, astigmatism, farsightedness, nearsightedness, into the lens. It was developed in Europe over a decade ago. It's been FDA approved in the United States since 2017. So it's been in the United States for over 3 years, almost 4 years. The FDA trial showed a 92% success rate in giving 20/25 or better vision without glasses. 92% of patients were within a very small amount of the target of the goal of doing the cataract surgery. And just as a frame of reference, that's the same success rate as what we publish with LASIK. So here's a procedure that can give us the success rate for the first time that compares with doing a refractive laser procedure that millions of people have had done. In the FDA trial, patients were twice as likely to be 20/20 without glasses than the control after 6 months. And as I said earlier, there's no other lens implant FDA trial that's shown greater than an 80% success of 20/20 vision without glasses or within a half a diopter of target in the past. So you're twice as likely to be 20/20 without glasses than the control. And it's not rocket science. This is common sense. Trying to predict an outcome is never going to be as successful as treating the outcome. You see what the outcome is, you treat the outcome, that's always going to be more successful. Long-term studies, as far as the stability of the lens is concerned, they're out more than 7 years. The idea here is that this is a silicone lens that is incompletely polymerized. Once you polymerize it, after surgery, then it acts like any other silicone lens, and silicone lenses have been used in the human eye for 40 or 50 years. Here's how the process works. Standard cataract surgery, instead of putting a standard monofocal lens in, you put a light adjustable lens in. Because the lens responds to UV light, this is one of the downsides of this procedure, because the lens responds to UV light, you have to protect the lens from exposure to UV light, or the UV light will do things to the lens which are bad. So there are special protective glasses that need to be worn during all waking hours until the treatments are completed. So after surgery, the way the treatments work is that this is a little bit like giving someone a pair of glasses. So after cataract surgery, if we do standard, regular run-of-the-mill cataract surgery, about 2 to 3 weeks after surgery, things have healed up enough, the prescription, the glasses reading is stable enough that we then hand the patient a glasses prescription. Well, that's not the way it works with a light adjustable lens. You measure the patient for their glasses prescription 17 days after their surgery, and then instead of handing them their prescription for glasses, you go over to the instrument that's in the office and you punch their prescription into the machine, the light delivery device. That light delivery device incorporates that prescription into the lens inside of the eye. After the first treatment is done, additional treatments are done every 3 to 4 days. You can adjust the lens up to 3 times, which is amazing flexibility. And I'll give you some examples of why that's important. The process goes pretty quickly once you get started, but wearing the glasses, you have to wear the glasses to protect the eyes for 3 to 4 weeks until things are completed. Here's how the process works. Again, not very complicated, but the instrument that does the light delivery is very complicated. It has thousands of lenses that focus the UV light on specific areas of the lens based upon a mathematical formula of the prescription that's entered into the machine. Polymerization of the silicone macromers causes migration of the non-polymerized silicone, and that effectuates the change in shape of that intraocular lens. That takes about 24 hours to have its effect and to change the lens shape to correct the vision. Sort of like putting a pair of glasses inside of the eye. And you are manufacturing that lens inside of the eye, customized to the prescription that eye requires. Sounds too good to be true. There are some limitations to this technology. One, your eye must dilate pretty widely, greater than 7 millimeters in our language, because you need to treat the entire lens. The light has to be applied to the entire lens to give the treatment and also to finalize or fix the treatment. There are some medications, oral medications, that are a contraindication, or those medications need to be stopped for some period, including hydrochlorothiazide and some tetracyclines. Hydroxychloroquine is another one. So you have to be careful with that. The reason is this instrument is delivering a pretty intense beam of UV light, and the medications can absorb that light in the retina and, in theory, cause some harm to the retina. And again, as I said earlier, you have to wear the special UV protecting goggles for the entire treatment period until 24 hours after the final treatment is completed. Let me give you some examples of some cases and some head scratchers for cataract surgery. So case study number 1, a refractive surprise. So I alluded earlier to the fact that predictive models cannot always predict the outcome 100%. So in this example, I had a 76-year-old patient who wanted to be glasses independent. And so she chose a multifocal lens to try to get both good distance and good near vision. We used a laser as well to treat the astigmatism. After surgery, both eyes had a slight amount of farsightedness and a slight amount of astigmatism. Not horrible, but she had a weak 20/25 vision in the distance and was unable to read comfortably and consistently without glasses. She also complained about halos around lights at night. So what are our options with this? In the past, you get what you get with cataract surgery. There's not any adjustment that one can do after it. So you had to talk about, 1, wear a pair of glasses, which is obviously not the intent. 2, talk about doing a lens exchange. Are you going to go back to the operating room and take that lens out and put another one in? There are risks associated with that. 3, you could have a LASIK procedure done. That is another invasive surgery with, LASIK is not perfect for everyone. We live in Colorado, dry eyes are a problem. Having LASIK can also affect contrast sensitivity. So these are problems that every cataract surgeon deals with, an imperfect outcome. Let me give you a similar example of a patient who had a light adjustable lens. So case study number 2, changing your mind. So a 67-year-old patient wanted to be glasses independent at distance. She didn't mind wearing reading glasses. She'd been doing it for quite a while and was very comfortable wearing $5 cheaters. The surgery was performed using the light adjustable lens in both eyes successfully. After surgery, both eyes had slight farsightedness and a significant amount of astigmatism, and we knew that, and we knew that we were going to treat that. The first treatment that she had done resulted in excellent 20/20 distance vision without glasses in each eye. She came back 3 or 4 days later, and she said, I'm a nurse. I need to be able to work on the computer. I need to be able to see in the intermediate. I'd like to be able to read. I can't see anything up close. This is frustrating to me. So we decided to put a trial contact lens on her non-dominant eye to see if her brain would tolerate the ability to use one eye to see better at the intermediate range and one eye to see better in the distance. That is a concept that's called monovision. And there are variants of that, larger differences between the two eyes, smaller differences between the two eyes. The important point, some human brains cannot tolerate having a difference between the two eyes. You don't know until you do it. So we put her in a trial contact and had her walk around the office with her fancy glasses on, of course. She loved it. So then the next 2 treatments, we made that eye a better intermediate eye for her. And then we finalized it, and she was much happier. That is not something that you could do in a non-invasive manner with any other technique, unless you're willing to take the lens out of the eye and put another lens in, or doing LASIK or PRK. The last case I'd like to talk about is, again, treating the result. Case study number 3, a 74-year-old, this was recently, a 74-year-old patient who wanted to be glasses independent as much as possible, a distance, but he was unsure if he could do monovision. He did not know beforehand. It's difficult to test patients for monovision success when you are seeing them because they have cataracts. Their vision is not very good. It's a very poor way to assess whether their brain can tolerate seeing very well in the distance in one eye and near up close. Surgery was performed using the light adjustable lens successfully in both eyes. After surgery, both eyes had significant unpredictable farsightedness and astigmatism, so a refractive surprise, which happens to every cataract surgeon up to at least 10% of the time. So you targeted for perfect distance vision, and they ended up being far more farsighted or more nearsighted than intended. And again, that's because you cannot predict the outcomes 100% of the time. And traditionally, when this happens, this is every surgeon's nightmare because patients are unhappy, they're not getting what they expected, you did not get what you expected, and you have to talk about invasive options to try to make that better, or you're going to put that patient in glasses more than they intended. This would have been an unhappy patient with any other approach. But with the light adjustable lens, you can just clean that up. You can treat a very wide range of refractive error. The light adjustable lens can correct up to 2 units of farsightedness, 2 units of nearsightedness, and up to 4 units of astigmatism. That is a tremendous range to be able to correct your outcomes after cataract surgery. So after the first treatment, he had 20/20 distance vision in each eye. He returned 3 days later when we put a trial contact over his non-dominant eye to test him out to see if he would like the monovision. And sure enough, he said, I love that, but there's no way to test that out with traditional cataract surgery and being able to treat that, again, without LASIK. Second treatment improved the near vision significantly in his non-dominant eye, which enabled him to see not only clearly on the computer, but to read fairly well without glasses. One of the things that the light adjustable lens does, if you adjust the lens for near vision, it does incorporate something we call negative spherical aberration, which gives an extended depth of focus so that you can target a patient with that lens for the intermediate range, and their near vision will be better than a monofocal lens. It's a little bit like a multifocal lens. It will work a little bit like that in giving you a bigger range. So in my experience, the light adjustable lens, major advantage is the ability to correct any refractive error hyperopia, myopia, nearsightedness, farsightedness, astigmatism after surgery. Major advantage in the ability to adjust up to 3 times. Patients can change their mind, and you can still change the result. Major advantage is the ability to experience the outcome and then to decide what you want your desired outcome to be. I do not mean to say this is superior to all other technologies. Every technology has its place, and it's important to have multiple tools in the shed. But other technologies like a multifocal lens or an accommodating lens, they absolutely can give superb outcomes, and the majority have superb outcomes. But predictions can never be as accurate consistently as treating the outcome. One of the other areas where this type of a technology is welcome and we're very excited about is taking care of cataracts in patients that have had previous LASIK, previous PRK, and previous radial keratotomy. When the eye has been surgically altered, these prediction models become even more inaccurate. So having the power to be able to treat the outcome after the fact is even more valuable in these patients. This technology takes the complexity a little bit out of the operating room. We're not using a fancy laser. We're not using a lens implant that has to have a perfect surgery and moves it to the clinic. We're doing the treatments based upon measurements for glasses for the refractions based in the office. There are some criticisms of the light adjustable lens that I want to address. One, other surgeons say, you know, my surgical results are good enough. They're good. And I wouldn't argue with that. My surgical results are good too, but are they 100%? We're always striving to have better outcomes, you know? And I don't think there's an honest surgeon on the planet that would say that refractive surprises or unintended outcomes, you know, aren't the bane of our existence. They consume a lot of time in counseling patients and talking to patients. Realistic expectations about the unpredictability of human anatomy and any type of a surgery is a very, very important topic for any patient to know for any surgery, much less cataract surgery. The other criticism is still just a monofocal lens, and that's a valid one. It is a monofocal lens. It is a lens that does not give you the ability to focus at different distances. And I think the counter argument to that is that the accuracy and superior optical performance are an advantage for this lens. So if you can give someone better than 20/20 vision or 20/15 vision without glasses, their stability, their functioning without glasses is going to be better and it's going to last longer. And again, as I talked about earlier, there is this sort of multifocal effect that you can get out of this lens with the way it's treated for the intermediate or near vision. Another criticism is why would I do this fancy technology? Just do LASIK after surgery. And there are surgeons that do that. If they have an unintended outcome or the patient's unhappy, they just have them have PRK or LASIK, and that is commonly done in this country. But having LASIK is not without its risks. Dry eyes is one of them, especially here in Colorado, and again, the effect on contrast sensitivity. The last criticism, which is very valid, is it takes too much time. There's a lot of chair time involved with this lens. Surgically, not. But in the office, each treatment involves dilating the eyes. It takes 90 seconds to 120 seconds to do each treatment. It takes on average 3.6 treatments to finalize the lens, so there's at least 4 visits. So you get to know your surgeon pretty well, which I like, but you know, it is a bigger time commitment than some of the other technologies. And I think the easiest way to look at this, as I've harped on throughout this talk, is that prediction versus treating the outcome. And the analogy I like to use for patients is like buying a suit or a dress off the rack. Okay, it's not custom fit for you, and chances are good that it may fit you perfectly, but it may not. And there is no way that an off-the-rack suit or an off-the-rack dress can compete consistently with the accuracy of a tailor-fit suit or a seamstress-fit dress. As far as pros and cons of, our top-end options and comparing them, the light adjustable lens, again, accuracy I think is its real strength because you're treating the outcome. Because it's a monofocal lens, there aren't halos around lights. There are very little dysphotopsias. The weakness is, if you can't tolerate a difference between the two eyes, if you can't tolerate monovision, then obviously you'd want to keep both eyes paired together. Multifocal lenses have, the strength is good distance, good near. Weaknesses are halos, this thing called dysphotopsias, and the risk of a refractive error. That's farsightedness or nearsightedness that cannot be predicted based upon measurements preoperatively 100%. That weakness also applies to the accommodative lens, which gives very good distance vision. The biggest weakness to that lens is that it gives an unpredictable focusing ability between patients. Honestly, from a quality of life and daily living perspective, what matters most in outcomes? We're doing a lot of activities at intermediate range. That's a big part of our lives. There aren't many people that drive for a living. You don't need to see the mountains clearly to survive, but we do need to do things like read a menu, shop, talk socially. These are intermediate range things. And, having the ability to try before you buy, or it's like test driving a car. Most people wouldn't buy a car without test driving it, and that's the advantage of the light adjustable lens. I would say, we all want to be free of glasses, and in my mind, there are 5 ways to achieve glasses independence. Number 1 is just do standard surgery and have low expectations. I went to a third world country a year ago, Guatemala, and those are people that are running around blind. They can't see light. And so they have cataract surgery. They can't afford glasses. They can't afford reading glasses. But they're glasses free, and they're happy to be glasses free. Obviously, that's a very low bar. The second way we can be free from glasses is to do standard surgery with monovision. One eye distance, one eye focused for the distance, the non-dominant eye focused for near. As I said earlier, not every patient's going to like that, and it may require something like a refractive surgery, LASIK or PRK, to achieve that kind of glasses independence. The third way is a multifocal lens. Multifocal lenses have weaknesses in that the brain, there's a significant amount of neural adaptation, so not every human's brain can use it, and you still have that spherical error that can occur. You can get a refractive surprise with that. The fourth way is using an accommodating lens. The strength there is that the distance vision is typically a little bit better than the multifocal lens, but it has an incredibly variable focusing ability between patients. And then the last is the light adjustable lens, offsetting the two eyes a slight amount. Now, there was a study that compared the success rate of achieving 20/20 vision, distance, intermediate, and near, between light adjustable lens and a multifocal lens. Is the two different materials or brands, or Symphony lens and a Panoptix lens. And the light adjustable lens was found to achieve a higher percentage of 20/20 at near, intermediate, and distance vision than for either other lens implant type without altering the stereo vision. So if you'd ask me, statistically speaking, what's the approach that's most likely to give me glasses independence, I would answer the light adjustable lens. So in 2021, cataract surgery protocol, a good option, standard surgery. It's covered by our insurance. There are no hidden fees. It's covered by Medicare. But depending upon how much astigmatism you have, you may need glasses for best distance vision. You certainly will need glasses for reading. A better option is using the femtosecond laser and using a standard lens, because that has the ability to treat astigmatism. Now, the laser is a little bit limited. It cannot treat a large amount of astigmatism, but it does a very good job of treating low levels of astigmatism. So that can reliably give you better distance vision without glasses than standard surgery. You still have the unavoidable risk of the surprise, of spherical error using the laser, because again, that's a predictive model. Best option number one, laser plus either a multifocal or an accommodating lens. And until the light adjustable lens was available, this was our number one premium option. But again, because of the unavoidable risk of spherical error, anywhere from 5 to 10, even more % of people could be unhappy and have an unintended outcome based upon the inaccuracy of this prediction model. So the light adjustable lens, excellent distance vision. The places where the light adjustable lens is very attractive is if a patient tells me, I want to see great in the distance. I don't care if I have to wear reading glasses. It will reliably give you great distance vision without glasses because it's a monofocal lens and we're adjusting it to that. Or if you've used monovision in the past, you wore contacts for 10 or 20 years with monovision and you know you like it, you know you want that after cataract surgery, this certainly can give you that in a very predictable way. It's also superior for patients who've had previous LASIK, PRK, or RK, any previous refractive surgery where things are even more unpredictable. It allows you to try it on before you decide what you want. So I gave you an example of someone who changed their mind and we were able to change the lens slightly to achieve that goal for the patient. Treat according to experience, not prediction. So in conclusion, cataract surgery is evolving very rapidly. The laser's been out for 6 or 7 years, light adjustable lens for 3 years. You know, this is a very rapidly evolving space, so it's important to have all the tools in the shed to give patients the best outcome possible. I enjoy customizing the personal treatment, so you know, it's very important to talk to patients about realistic expectations, what the strengths and limits to all of these technologies are. You know, I believe that the best approach for a patient to take with cataract surgery is to think about what their goals are and work backwards from that. What do I want to achieve? What do I want to be able to do after cataract surgery? Do I care if I wear glasses or not? Do I want to be glasses independent? No single approach is best for every single patient. And most importantly, talking with your surgeon. You know, this is very complex stuff and you know, it's difficult for us to predict what our brains want without experiencing it. And so, you know, you really have to put a lot of thought into this and talk about all these options. So you have to talk with your surgeon and have extensive discussions about what your expectations are, what your goals are, and try to match up the approach to meet your goals. Thanks for listening in. I'm not sure if we have any questions or not. I assume we do.
We sure do. Thank you so much. That was really wonderful information. We have a lot of questions, and we'll get to as many as we can in the time we have left. So I'm just going to start.
Shoot.
All righty. Okay. We have a lot of questions about macular degeneration. You may have covered this, but I'm going to ask it. This viewer says, I have mild macular degeneration. Is it possible for me to have my close-up vision corrected during cataract surgery?
So macular degeneration, for those that don't know, is a genetic condition where the retinal cells, over decades and decades of use, atrophy, they become worn out. And there's two forms, there's a dry form and a wet form, both of which affect the central vision. So in its extreme form, macular degeneration can steal your central vision. So you have a black spot in the middle of your vision. In patients that have comorbidities like this, they have other eye diseases, I at least tend not to push fancy technologies because it's hard to predict how good the vision is going to be when you have macular degeneration, okay? If you don't have a 20/20 retina, you are not going to have a 20/20 outcome after cataract surgery. In addition, specifically with regards to the light adjustable lens, macular degeneration is a contraindication because you are exposing the eye to a lot of UV light and there is some possible increased damage to the macular degeneration. So my discussions with patients with macular degeneration tend to focus more along standard cataract surgery because you're uncertain, you know, what the outcome is going to be. Yes, you can choose a lens implant in answer to the question that gives the focus up close, but that is still not going to fix the macular degeneration. So even though you have a lens implant in your eye that should give a normal eye perfect near vision, if you have macular degeneration, you're unsure how that's going to turn out. There's no guarantee that's going to be perfect reading vision.
What is the principal reason that the preoperative prediction turns out to be inaccurate?
Anatomical variation.
Okay.
Not every eye is exactly the same. You know, these models are based, everything's a bell-shaped curve, right? Shoe size, height, eye size, where the lens sits inside of the eye. The effective lens position is a big component of this. Microns of change can affect the prescription dramatically, where the lens heals in place. And these are factors that are not, we can't control them surgically. We can do surgery perfectly, and that lens may heal or be in a position that leads to an unexpected outcome.
What is the potential impact from the recently announced development process of eye drops to clear the cataracts?
So the ability to clear, let's think about this from a biological perspective. The human lens is in essence a cyst. It's proteins and cells that are contained within a capsule where macromolecule cells do not go in or out. That's why it's a cyst. It's a closed system. And over time, those proteins become denatured and become cloudy. Number one, it's very difficult to get penetration of any drop that's given to the eye into it. To my knowledge, there is no non-surgical treatment that will reverse the effects of cataract. In the future, there may be a treatment that helps prevent them, but once the cataract forms, there's no way to reverse that process. I mean, this is asking to reverse the aging process, in essence, and reverse it in a pretty dramatic way. You know, if you're an 80-year-old that has a cataract, you know, the lens that you want in your eye needs to be a 20 or 30-year-old lens. And, you know, my honest opinion is that is not something that's going to happen in my lifetime.
What if you're allergic to the artificial lenses that are implanted? This viewer has multiple chemical sensitivities, and I'm concerned about that.
So allergy to the lens implants doesn't occur inside of the eye.
Does not?
Yeah, and it's kind of a fascinating story. This is one of the reasons the intraocular lens was developed. I mentioned in an earlier slide, Sir Harold Ridley was the first to notice during World War II that fighter pilots that got shot down would have shrapnel from the windshields in the airplane embedded in their bodies. And he noticed that if they had a little piece, and that was polymethacrylate, World War II, that was the invention of that plastic material. And he noticed that if they had a piece embedded in their eye, it did not elicit an immune response. And that's what led him to design the first intraocular lens. Yes, you can get inflammation inside of the eye from these materials, but they are very well tolerated from an immune system perspective.
Would you do both eyes or one at a time?
For me, it's a golden rule thing. I know that Kaiser, for example, does both eyes at the same time, cataract surgery at the same time. I am not yet doing that. You know, there may be reasons to move that direction, but for me right now, I like to do one eye at a time and make sure that eye turns out well, and we'll do the eyes 1 week apart. But, you know, if I'm having cataract surgery, I'm going to do one eye at a time. Maybe you call me old school, I guess.
All righty. How might cataract surgery affect lazy eye? Any lasting negative effects?
I'm sorry?
How might cataract surgery affect lazy eye?
So lazy eye, or in the medical vernacular, it's called amblyopia. And that occurs in kids where the brain really doesn't fully develop that visual neural pathway to be able to see clearly in one eye. So anatomically, the eye is completely normal. But the neural pathways that go from the eye to the brain are not fully developed. Cataract surgery does not correct nor change that. So if you have always had an eye that's never seen as well as the other, that is not going to change after cataract surgery.
Does Medicare cover the 4 classes of lenses?
No. Medicare covers the cost of option 1, which is a standard lens. Any of the other options, toric lens, accommodating lens, multifocal lens, light adjustable lens, those lenses are all designed to reduce your dependence upon glasses. And Medicare and all insurance treats that as a cosmetic approach. So no insurance covers the added cost of these premium technologies.
All right. The next question is, how much do LAL lenses cost? My insurance does not cover it. So do you have a...
What's that?
We have time for about 4 more questions.
Oh, okay. So yeah, the cost can range anywhere from $1,500 an eye to $3,000 an eye, depending upon which technologies you're using. But you're definitely looking at a few $1,000s to choose one of these technologies. So it's not cheap. It's expensive technology. There's no question about it.
Can old cataract surgery be repeated?
Great question. So cataract surgery is, typically once per eye per life. It cannot come back because the lens is removed. Once cataract surgery is done and the lens implant is inside of the eye and it scars in place, going back into that eye is higher risk than the original cataract surgery. So we try to avoid it at all costs. And the only reason we do it is if we don't really have a choice. So in essence, cataract surgery is a one and done kind of concept.
Does every eye surgeon offer the light adjustable lens?
No. I've done more. My practice, Boulder Eye Surgeons, is the only practice in the state that currently does the light adjustable lens. I've done more than anyone else in the state.
Perfect. What is the best way to choose a surgeon? Are you the only surgeon in Colorado that does LAL? I'm sorry, that's sort of a same question.
Yeah, I mean, how do you choose a doctor? How do you choose a surgeon? I think I tell patients all the time, you want to be comfortable, you want to have a good feeling about it, and I'm a big fan of second opinions as well. So, it's your body. It's not the surgeon's body. So you want to feel comfortable going into it. There are complications for every surgeon on the planet. Any surgeon that says they never have a complication is either lying or they've never done surgery. And so you need to know when you choose someone, if there is a problem, you felt good about that choice.
And we have time for one more question. Can I do light adjustable lens in one eye since I already have monovision?
Absolutely. Yeah, I've done that already on a number of patients. Absolutely. I've done in one eye in patients that their other eye's already been done, and they're not as happy with that eye, and so we chose a light adjustable lens, and they've done wonderfully. You absolutely can do that. There is an advantage to doing both eyes because you're treating them at the same time, but if it's the second eye, it absolutely is very reasonable.
And our last question, what is a unit of nearsightedness?
A diopter.
A diopter.
And that's a focal point of one. So if you're 1 unit of nearsightedness, that means your focal point, your ability to focus, is 1 meter away, about 3 feet.
Ah, okay. Very good.